Good morning, everyone. I'm Sir Franz, and for this lesson of Pharmacology 2, our topic will be coronary syndromes. And these sets of disorders imply the coronary artery as the source of the disease, knowing that the coronary artery is the special circulation of the heart by which blood flow reaches the myocardium, the contractile unit, the functional unit of the heart. So there are many forms of coronary syndromes, and in general, these are also called ischemic heart disease. The adjective ischemic means that there is inadequate oxygen delivery, and this inadequate oxygen delivery leads to disorders of the heart itself or pathologies of the myocardium. These are the different forms: stable angina pectoris, unstable angina pectoris, non-ST segment elevation, myocardial infarction, and ST segment elevation, myocardial infarction. Ischemic heart disease represents a group of related entities resulting from myocardial ischemia. Again, ischemia is the inadequacy of oxygen-rich blood to an organ. And this time, that organ is the myocardium or the heart. An imbalance between myocardial supply or perfusion and cardiac demand for oxygenated blood. Okay, so this diagram shows us the condition by which ischemic heart disease develops, and represented here is the balance between oxygen demand of the myocardium and oxygen supply. So whenever this balance is tilted towards an increase in oxygen demand that is inadequately compensated by oxygen supply that is reliant on coronary blood flow, ischemic heart disease results, and that there is a spectrum of ischemic heart disease. All of those has this as their central pathogenesis: angina pectoris and the different forms of myocardial infarction. So, what are the factors that result to a decrease in coronary blood flow, which means a decrease in blood flow to the artery that supplies the myocardium? There can be a decrease in vessel caliber. So that means that the space or the lumen of the coronary artery is decreased, most commonly due to an atheroma or a thrombus or a blood clot. So by decreasing the lumen of the artery, the amount of blood that can flow distal to that point of occlusion decreases, so that the oxygen delivered to the myocardium also decreases. Another factor is an increase in heart rate, and this relies on a decrease in diastolic filling time. So the point of time the point of time by which the coronaries are filled with blood is during diastole. And that means that blood is filling the ventricles. And when the blood is filling the ventricles, the associated activities during the cardiac cycle include a backflow of blood that has already entered the aorta. And when that blood backflows into the aortic valve, a portion of that blood is shifted towards the coronary vessels. And so at that point in the cardiac cycle, the coronary vessels are filled and the myocardium is supplied with blood. Whenever the time of filling decreases, then coronary blood flow decreases. Another reason of decreased coronary blood flow is a decrease in perfusion pressure. And this usually relies on the volume of blood that is available. Next is an increase in ventricular wall tension. Whenever the ventricles have transformed into something that is thicker or larger, than when it is filled with blood by way of the coronaries, due to the increase in the mass of the ventricular wall, there is compression of the intramyocardial vessels, which effectively decreases coronary blood flow. The factors that increase oxygen demand revolve on the rate of myocardial metabolism and utilization of oxygen. And this rate of oxygen consumption and metabolism is dependent on the workload of the heart. So the workload of the heart um, is a factor of cardiac output, how much blood the heart will have to pump out per minute. And so the determinants of increased oxygen demand are increase in heart rate, contractility, and ventricular wall tension. Also, preload and afterload. As you will observe, these factors are modifiable by drugs that we have discussed already in the treatment of hypertension. In more than 90% of cases, myocardial ischemia results from reduced blood flow due to obstructive atherosclerotic lesions in the epicardial coronary arteries. Epicardial means that the coronary arteries are situated outside the heart, just on top of the heart. So we have already discussed dyslipidemia and its consequence of atherosclerosis. Coronary ischemia or myocardial ischemia is most commonly caused by atherosclerosis. Next, let's discuss the normal endothelium. The endothelium is the layer of blood vessel that is innermost and comes in contact with the blood. Remember that the blood vessel, aside from the endothelium, has the tunica media, the middle layer, and the tunica adventitia, or the outermost layer. So the innermost layer, the tunica intima, has as its functional unit the endothelium. The endothelium has dynamic interaction with blood and extravascular tissues. So, it is important in inflammation, by which white blood cells that are produced by the lymph nodes and the bone marrow traverse the blood vessel, penetrate the endothelium so that they can enter the extravascular space or the tissue that requires the inflammation. And this process is quite complex in that the white blood vessels will have to signal to the endothelium by way of cytokines so that the endothelium will express adhesion factors so that white blood cells that are present in the blood can enter, attach, and enter the endothelium. Next, the endothelium also understands the oxygen demand of the tissues by which it is found, and by understanding the oxygen demand of these extravascular tissues, the endothelium controls vascular tone, which basically means how much the blood vessel is opened so that blood flow is increased by way of vasodilation in instances where the extravascular space requires a lot of oxygen. The endothelium is not a static tissue. Okay, hindi lang siya um, dinadaanan ng dugo, hindi lang siya tissue na by which blood comes in contact with, but it is dynamic and it is responsive to the needs of the parenchyma or organ, and it maintains an antithrombotic milieu. So it naturally has properties that prevent coagulation of blood. I think you are already familiar with this slide, and this slide shows us how an atheroma develops and what can happen to the atheroma, which will lead to the clinical outcomes or the outcomes in the patient that we see. So first, the normal lumen is free of any fibrous tissue, of any fatty tissue. So this lumen maintains an anticoagulant property, and it maintains smoothness so that blood flow is laminar and not turbulent. Whenever the person is exposed to risk factors such as endothelial dysfunction, whenever there is excess systemic inflammation, there can be endothelial dysfunction. When there is increased monocyte adhesion or emigration, white blood cells will stick to the endothelium. When there is smooth muscle migration into the intima, recall that the tunica media, the middle layer, is what holds the smooth muscle. Whenever the smooth muscle in the middle layer enters the inner layer, that will increase the propensity of this blood vessel to contract. Whenever there is excess production of extracellular matrix, and whenever there is lipid accumulation, a fatty streak can develop. Okay, so these risk factors are the pathogenic processes that occur in the development of an atheroma or a plaque. So the normal coronary develops a fatty streak, as you will see, and then with this and continuation of the pathogenic activities that we've discussed a while ago, there can be thickening of the innermost layer of the blood vessel, and this is a function of inflammation. Okay, so with that and without control of the risk factors, especially dyslipidemia, an abnormal level of lipid in the blood, the plaque will continuously absorb cholesterol that is present in the blood, and by doing that, it expands. So there is expansion of the outer wall to maintain internal diameter. What does that mean? If you will compare it with the normal coronary, the size of the blood vessel itself remains constant. But whenever there is already a plaque, an atheroma that has developed in the intima, one compensation of the blood vessel will be to increase its overall size, so that even if there is already occlusion of the luminal space of the coronary, blood flow to the distal portions of the occlusion is maintained because the overall size of the coronary has increased, the lumen maintains its diameter. So this expansion of the outer wall continues as the atheroma progresses until at 40% of stenosis, this is already physiologically relevant. So 40% of the luminal diameter is blocked. Whenever 40% of this diameter is blocked, usually like that, this is already the 40% that has remained, the inner diameter begins to narrow already. And with this progression, there can be three forms of the atheroma. A thin capped atheroma, where the atheroma is covered by a thin layer of endothelium. A thick cap, where the atheroma is basically buried, okay, in the endothelium. And a fibrotic plaque, where the atheroma is covered with a dense layer of collagen. And this fibrotic plaque is technically um, more stable than the other forms. Okay, so when the atheroma has already developed, what we are afraid of are sudden events and changes. So the plaque can rupture, and remember our lesson. The endothelium maintains an antithrombotic state. When the plaque ruptures and the endothelium is lost, the plaque exposes collagen, and this collagen that is exposed into the lumen is readily detected by platelets. And around the exposed collagen fibers, the platelets aggregate and they develop clots at that region. There can be continuous erosion and thrombosis. So whenever the uh, erosion of the plaque ensues or the fibrotic cap ensues, then portions of the atheroma can technically bud off and embolize the distal and smaller coronary vessels. Okay, and there can be calcification of the plaque. So this process by which there is erosion, the body compensates by adding calcium into that site so that the calcium stabilizes the plaque, making it harder. So these sudden events, plaque rupture, erosion, and thrombosis, can lead to sudden cardiac death as um, the thrombosis can occur very rapidly and the loss of blood flow to the myocardium can occur very rapidly. When the myocardium dies, then the heart won't be able to pump, and so the person dies. Or the erosion and the thrombosis, together with calcification and fibrosis of the plaque, can lead to critical stenosis, where chronically and gradually blood flow to the myocardium is decreased, okay, steadily but continuously until such a point in time is reached when blood flow is about 25% of what was normal or 20% of what was normal. Okay, and here the patient lives but continuously experiences chest pain and continuously the heart is failing. Okay, so in most cases there is a long period of silent, slow progression of coronary lesions before the sudden onset symptoms. So let us first discuss the initial form or the first form of a coronary, and that is angina pectoris. Angina means pain, and pectoris means chest. So angina pectoris is chest pain. And this chest pain is because the heart is the one uh, where source of pain stimuli comes from, no? So the heart is the source of the pain stimuli. So how do we know that the heart is the source of the chest pain and not just the muscles of the chest or the bones of the chest, the cartilage of the chest, not the skin of the chest? How do we know that the chest pain comes from the heart? So first, it is retrosternal, which means at the middle of your chest, where your sternum is, the pain is deeper. No, it is not in the sternum or above the sternum. It is behind the sternum, and it is intense. The pain, aside from occurring in the sternum, retrosternally, radiates to the left shoulder. So included in the pain is the chest, the left shoulder, and the left, usually ulnar aspect or inner aspect of the left arm and hand. And the reason for this, together with radiation to the neck, the jaw, teeth, the back, and abdomen, is because these regions, the heart, the left arm, the left neck, and face, are derived from a common embryologic source. And so the free nerve endings that are subserving these regions share a common pathway with the free nerve endings subserving the heart. Okay, so this is classically described as a crushing or squeezing substernal sensation that can radiate down the left arm or to the left jaw. This is caused by a transient, which means it is not permanent, around 15 seconds to 15 minutes of myocardial ischemia that is insufficient to induce the death of heart muscle cells. Chest pain or angina pectoris can be further divided into stable angina pectoris and unstable angina pectoris. The characteristics that make angina pectoris unstable are if it is very severe and has at least one of these three features. The chest pain occurs at rest when the person is not doing anything and it lasts greater than 10 minutes. So, understand what the factors are that entail coronary artery oxygen supply and coronary artery oxygen demand. Okay? So those factors are at play. When an organism is doing strenuous activity, the heart will have to pump a lot harder to supply the systemic circulation with enough oxygen. And so when it pumps harder, then its requirement for oxygen increases. Compare that to the normal resting individual where there is no need for the heart to pump harder and the oxygen requirement of the heart is not increased, but angina still occurs because the oxygen delivery side of the balance is affected. Next, it is of recent onset, which means it has occurred only less than 2 weeks. third is a crescendo pattern, which means that as more and more occurrences of chest pain happen, the quality of further chest pain becomes increasingly more painful. It is distinctly more severe, it is more prolonged, or more frequent than previous episodes. So stable angina pectoris would not have these features, and usually they will occur with excessive physical activity or excessive emotional outbursts. Okay, so what is more concerning would be the unstable angina pectoris. What could be the disease processes that occur so that these unstable features result? No? So this is what we have to know further so that we can stratify these patients. Is this patient at increased risk of sudden death? Okay, so that is the question we need to find out. That is why we have to determine if the angina is stable or unstable. So a myocardial infarction, we have already crossed, okay, um, the, the line separating the different forms of ischemic heart disease. When we're talking of myocardial infarction, there is already death, irreversible, no? Irreversible death of heart muscles. Doon sa dalawa sa angina, we do not know or there is no death of heart muscle. But here, there is already death of myocardium. A myocardial infarction is commonly called a heart attack. Okay? It is the death of cardiac muscle due to prolonged ischemia. And the key adjective that we'd like to use here is irreversible death. Why? Because muscle has many different forms, diba? It has smooth muscle, striated muscle. Striated muscle can be skeletal muscle or cardiac muscle. Well, the rule is in the human body, the tissues that are more specialized and more advanced in their development have a lower ability to regenerate. And so, myocardial tissue is one of those specialized tissues that have virtually no ability to regenerate unless we intervene. Again, this is our pathogenesis, normal, plaque development, plaque events, including the rupture of the plaque, erosion and thrombosis of the plaque, and calcification of the plaque. One of the outcomes would be sudden cardiac death, and this is the result of myocardial infarction. Okay, so I encountered this in Facebook. My concerned friend, food won't fill that void in your heart. And we, as scientists, pharmacists, a personal science, an atherosclerotic plaque. Okay, so this is, of course, an autopsy finding of myocardial infarction. And you will see that the regions of the myocardium which has been blocked, um, its coronary has been blocked, dies off. And you will see that the healthy, well-perfused tissues are colored red, but the portions of the heart which were blocked has eventually died off and has formed a fibrous scar. That is why it is already white. So this means that when this heart was harvested, this white coloration on its wall is a region of myocardium that has died ways way back, no, weeks or months before. Okay, and the region of the heart that has died recently would be the one with active necrosis. This one. Okay, so you can also see how this heart is um, has the consequences of hypertension. No, the ventricular wall is extremely thickened here. Okay, so this is a heart that has undergone infarction. So this is not the nooks and crannies of this slide is not your competence, but I'd like to show how, at an overview, we evaluate patients who come in with chest pain. So first, we look at the presentation. What is the location and the distribution of the chest pain? It can be pinpoint, widespread, no, and with varying degrees of that spread, or the patient can come in arrested. Logically, if the patient comes in arrested, another person or a healthcare provider may be performing cardiopulmonary resuscitation. And if this is the presentation of the patient, most likely we are dealing with a severe form of acute coronary syndrome. And most likely it's STEMI, but it can be NSTEMI. Okay, if the presentation is pinpoint chest pain, then more likely we are dealing with a non-cardiac source of the chest pain. Okay, next, we take out electrodes and we get an ECG reading, electrocardiographic reading. This is the normal ECG with P, Q, R, S, T. This is an ECG which shows ST segment depression, which is most commonly associated with cardiac hypoperfusion. P, Q, R, S, T. Okay, and here is an ECG showing ST segment elevation. P, Q, R, S, T. ST segment elevation. And ST segment elevation means that the entire wall of the heart is dead so that that wall will not repolarize. And so this is the manifestation. Okay. And this is definitely more severe than this one. Here, we may be dealing with hypoperfusion of the heart wall or the death of only a portion of the heart wall, usually the subendocardial heart wall is dead. After getting an ECG, we use blood markers. No? So these blood markers are cardiac biomarkers. We take blood from the patient and analyze if that blood contains a protein that is released by dying heart muscle. And that protein can be in many forms: troponin, CKMB, no? Myoglobin. Okay, so those are the different cardiac biomarkers. But here we focus on the most specific and the most sensitive, which means specific, if we see it, we're dealing with the death of heart muscle. Sensitive, that means if we see it, it has the chances of this person having a heart attack is very high. So the troponin can be mildly elevated, and we can see that in unstable angina, in other cardiac disease, and in non-ST segment elevation myocardial infarction. But here in NSTEMI and STEMI, there is a gradient by which troponin is um, very much elevated. Okay, so if we see at the outset that the troponin is very high, maybe we're dealing with STEMI, ST segment elevation myocardial infarction, the death of the entire breadth of the wall of the heart. So this is a very nice image showing to us, um, as a review and as a summary, the different pathologic processes, the different manifestations, the extent of injury to the heart, and the electrocardiographic manifestations, as well as the cardiac biomarkers, no? Comparing side by side the different entities in ischemic heart disease. So you can have just a fatty streak. Um, you will see that there is moderate oxygen demand causing um, angina pectoris. Okay, so usually the patient is exercising, coronary flow is adequate for the oxygen demand, and the myocardium is normal. And we see at V4, V5, and V6 the anterolateral chest leads, that the normal waveform of PQRST is seen, and the cardiac biomarkers are negative, which means that there is very little chance of this patient having a heart attack. Okay, so next, the plaque can enlarge and effectively decrease the lumen size, and there can be mild symptoms in instances of increased oxygen demand. Coronary flow is inadequate for oxygen need, and so there is myocardial ischemia. And our waveform patterns in the ECG on portions of the heart, um, the ventricles of the heart, no? Detected by chest leads 4, 5, and 6, we see some ST segment depression. And if we get the cardiac biomarkers, they are still negative. Okay, so this can probably be an NSTEMI or unstable angina. Okay, lastly, there is severe narrowing. The plaque has ruptured, and because of that, um, the contents of the plaque has been exposed to flowing blood, and an acute thrombus develops. Okay, even at rest, the patient with low oxygen demand experiences chest pain. And here, the process is a decrease in coronary flow, um, even for a decreased oxygen demand. Most likely, we're dealing with ischemia and injury, and because of that, heart muscle cells dying, the proteins that are found inside the heart muscle cell can leak out into the blood, and we see the presence of troponin and CKMB, creatine kinase, so they can be elevated. And because the entire wall is injured, we see ST segment elevation. Okay. Okay. So whenever we have already identified by using laboratory tests or by using the history, more importantly, what the patient tells us and what we see in the patient when we do a physical examination, we will already have an inkling that this patient has a spectrum, one of the spectrum of acute coronary syndrome. And knowing that 90% of ischemic heart disease is due to an atheroma of the coronary, our first step in the treatment of this patient would be risk factor modification. And by that we mean we test the blood of the patient for the quality of lipids present. So we order or check fasting lipid. And when we see dyslipidemia, we use dyslipidemic agents, no, anti-dyslipidemia, such as statins, HMG coenzyme A reductase inhibitors to prevent the synthesis of cholesterol. And once we have already done that, then that's one risk down the line, no? Um, we also advise smoking cessation. Why? Because the chemicals in smoking increase inflammatory mediators. They lead to abnormal metabolism of lipids and they promote vasoconstriction of the coronaries and other arteries. Next, blood pressure control. So our goal here would be to decrease the damage that occurs on the coronary because of an increase in blood pressure. Remember that one of the cause and also the target organ of hypertension, no, is the blood vessel. And here we control the blood pressure to less than 140/90. That's the hypertensive range if non-diabetic. And if the patient is diabetic, we provide stricter control at less than 130/80. Why? Because the damage to the coronary may not be only due to the increased blood pressure, but also due to the pathologic consequences of diabetes. Okay, so here, because the patient has diabetes, we have to be stricter because there are two agents causing the atherosclerosis. Also, we control other modifiable risk factors such as the diet, diabetes, and hypothyroidism, and etc. After risk factor modification, once we assess that the patient is still at risk, the first thing that we do is we provide antiplatelet therapy. So this can be in the form of daily aspirin with or without clopidogrel. So if with clopidogrel, this is already dual antiplatelet therapy, okay, which has its own risks. If the patient is still at increased risk, we set out this patient for testing, okay? So we can order stress testing where the patient will run at a treadmill, and while the patient is running at the treadmill, an echocardiogram is being performed simultaneously or an ECG is being performed simultaneously. Or this can be an invasive test where we insert nuclear isotopes with the patient, and those nuclear isotopes will find their way to the heart, and we measure the level of radiation emitted by the heart. Okay, that will tell us the functional capacity of the heart. So if we determine them to be high risk, we go with further evaluation. If low risk, then we add to the patients beta blockers and or ACE inhibitors, especially if diabetic. The beta blockers will decrease the heart rate, and so by decreasing the heart rate, the diastole will increase, no? The duration of diastole will increase, and so the coronary will be perfused more. And by also controlling the heart rate and inotropy, we are able to decrease the oxygen demand and or add an ACE inhibitor, which will lead to vasodilation of the periphery, decreasing the afterload, therefore decreasing the workload of the heart. If the patient has persistent symptoms, we add the second line anti-angina agents, nitrates, and or calcium channel blockers. If the patient has no symptoms, monitoring. If the patient still has symptoms despite beta blocker, ACE-I, nitrates, calcium channel blockers, we consider revascularization. So we insert, there can be two forms of revascularization. We insert a catheter, usually through the femoral artery in the groin, and it goes back to the heart. So dadaan siya sa aorta, and then it reaches the heart. And then at the level of the coronaries are entered, and the occlusion is scraped off so that the atheroma is physically dislodged. No? But this dislodgement has a catch basin so that it will not occlude distal smaller fragments of the coronary. So after niya i-dislodge, sasaluin niya din. Okay? So that's percutaneous coronary intervention. Or we can recommend to the patient that he or she undergo cardiac surgery, coronary artery bypass graft, where a blood vessel in the chest, no, in the chest wall is used, it is harvested, and it is sutured or connected to the coronary artery before the obstruction, and the other anastomosis or connection will be the coronary artery distal the obstruction. So you bypassed the obstructed coronary. Okay? Or we use ranolazine, which is actually an agent that increases the activity of the heart, at the same time decreasing its oxygen requirement. So this is reserved for patients who are not amenable to the reperfusion techniques or the revascularization techniques. This is rescue already if we can't do anything. Next, let us discuss antiplatelet therapy, which is the first pharmacotherapy that we provide to patients after controlling their risk factors. And our goal in the provision of antiplatelet therapy is to prevent platelet activation. And platelet activation is defined as the series of biologic steps undertaken by platelets to be more effective at aggregation, platelet sticking to platelet, adhesion, platelet sticking to the blood vessel wall, and degranulation, the platelet releasing its own stored chemicals. So these are serotonin and other vasoactive mediators. Okay, so for us to understand um, in general how antiplatelet therapy works, we need to know that there is a balance between different stimuli, and this balance is prothrombotic, means um, they would like to form a clot, or antithrombotic, preventing the formation of a clot. So these are balanced like a weighing scale. So, and the prothrombotic stimuli are thromboxane, serotonin, and adenosine. And the antithrombotic stimulus that is relevant pharmacologically is prostaglandin E. So, so this image first shows to us how the platelet, which is found in the blood, interacts with the endothelial wall, which here is already not antithrombotic because there's already been rupture of the plaque. And with disruption of the plaque, there is exposure of collagen and tissue factor, which will communicate to the platelet that some form of injury is occurring and um, you need to seal off this injury so that if this is a wound, blood can be um, preserved, no? So that clotting will occur. And so here is the interaction of exposed collagen with the platelet. So the exposed collagen will stimulate glycoprotein 1b, and once glycoprotein 1b, the receptor is activated, that will lead to platelet activation. Okay. Another stimulus of platelet activation would be the thromboxane receptor. So the thromboxane receptor has as its ligand thromboxane. And uh, remember that thromboxane is a modification of prostaglandin. And so thromboxane is integrated into the pathway for cyclooxygenase. So arachidonic acid is acted upon by cyclooxygenase, forming prostaglandin, and prostaglandin is acted upon by thromboxane synthase, forming thromboxane. Thromboxane binds to the receptor and activates the platelet. Next, um, platelets can also be activated by the binding of adenosine diphosphate. Okay, okay. So here uh, we take also a look at how platelets, aside from binding with the endothelium in a process we call adhesion, will also bind with fellow platelets in the process that we call aggregation. Okay, so this binding occurs through fibrinogen. Okay, fibrinogen cross bridges that are linked to the two platelets through glycoprotein 2b3a. Okay, so if you can imagine, this is the exposed endothelium. One platelet was bound there, and once it was bound, it was activated. And this activation promotes the binding of other platelets to the exposed tissue and other platelets with each other, forming a thrombus. Okay, so this is mediated by GP2B3A. Okay, another way by which platelets are activated is through thrombin. So remember that uh, thrombin is at the end of the coagulation pathway. And the goal of the coagulation pathway is to produce fibrin, which is basically like cement stabilizing the clot. So um, the product of that coagulation pathway, the enzyme active thrombin also activates platelets. Okay, not only the cement, but the bricks also. Okay, so yun yung analogy niya. Okay, so after knowing the interaction, again, endothelium, interaction with the platelet through exposed collagen. Okay, platelet being activated so that it will stick more with the endothelium and aggregate with other platelets. How is the platelet activated? By the collagen, by thromboxane, by adenosine, and by thrombin through PAR1. Okay. After activation, the platelet will release adenosine, which will feed forward yan, and stimulate itself and other platelets. The platelet will stimulate cyclooxygenase, and by production of prostaglandin, thromboxane will also be synthesized, leading to the activation of itself and of others. Okay, so where do we insert here in this mechanistic view the drugs which are purported to prevent this process? So we can block thromboxane by blocking cyclooxygenase 1 irreversibly via aspirin. Chemical name is acetyl salicylic acid. And this enzyme, cyclooxygenase 1, is irreversibly inhibited by acetylation, which is provided by aspirin. So, giving aspirin blocks COX-1, the levels of thromboxane A2 will decrease, and so the level of platelet activation will decrease. By decreasing the level of platelet activation, the platelet will not be efficient in binding to the exposed subendothelial tissue, and it will not be effective in binding with other platelets. Okay, so those are the end effects. We can also block platelet activation by blocking the receptor for adenosine by giving P2Y12, this is the receptor, P2Y12 inhibitors, clopidogrel, prasugrel, ticagrelor, ticlopidine, and cangrelor. So the most available for us would be clopidogrel and prasugrel. Okay? So mono antiplatelet therapy aspirin, dual antiplatelet therapy, or if the patient has adverse events that preclude him or her from the use of aspirin, we can initiate antiplatelet therapy with clopidogrel and other adenosine inhibitors. Blockade of the adenosine receptor, decreased platelet activation is the result. Decreased platelet activation, decreased adhesion, decreased aggregation. Okay, so we can also block aggregation by blocking the 2B3A receptor through the inhibitors such as eptifibatide and abscimab. A newer agent is tirofiban. Okay, so by blocking this one, the receptor, the fibrin chain will not be able to link the two platelets. Okay, so by blocking the synthesis of thrombin, okay, so you need for this to recall the coagulation pathway. So by giving thrombin inhibitors and by giving factor 10A inhibitors, the level of thrombin will decrease, and so it will also, through PAR1, decrease platelet activation. Next. So we have already established that the disease, which is ischemic heart disease, is due to a decrease in oxygen delivery and or an increase in oxygen demand. And that decrease in oxygen delivery is most commonly due to the blockade of the coronary arteries. And this blockade is due to um, structural causes, so um, an acute blockade by a thrombus, so a clot forming because um, the subendothelial tissues have been exposed, and or a very large atherosclerotic plaque or an atheroma. So if that is the cause and the case in 90% of patients with IHD, ischemic heart disease, then it will be very logical that in acute events such as plaque rupture and myocardial infarction, if we are quick to act, we can restore blood flow by disrupting the process, either a clot or an atheroma. So the goal of medical reperfusion would be to restore coronary blood flow before irreversible myocardial death ensues. So we have the golden period of reperfusion. The patient experiences chest pain, severe chest pain, and at that time, we don't know what form of IHD the patient is having. But if it were the case that the patient is having myocardial infarction, and STEMI or STEMI, the patient is losing myocardium as time goes by. So we have a golden period of 4 hours from the onset of chest pain. In that 4 hours, the patient will have to receive the medical reperfusion therapy, or else the myocardium of the patient will eventually die. So in these 4 hours, we can save myocardium. Therefore, we can save a portion of the heart and we can save the patient. Okay? So for medical reperfusion, we use tissue plasminogen activators. And the effect of tissue plasminogen activators, TPAs, would be to degrade fibrin. And by degrading fibrin, the cement, we produce disintegration of the matured clot. However, as you will understand, we are trying to lyse a clot, and therefore these agents are contraindicated in patients who will benefit from having a clot, such as in patients who have states associated with increased risk of bleeding. If they are bleeding, we want the clot to be there to prevent blood loss. Okay, so by using TPAs in these patients, we promote bleeding and therefore will be doing more harm. Patients with um, acute trauma or patients who are recovering from surgery, okay, um, particularly within the first week after surgery, prior hemorrhagic stroke, a CNS tumor, which has an increased risk of bleeding. Okay, so the tumor can bleed internally. That is why TPAs are contraindicated. And if there is actual bleeding, let us say from the gastrointestinal tract, the patient is bleeding, with into the lumen of the GIT, gastrointestinal tract. So here is a picture of how tissue plasminogen activators work. Okay, so you have there the fibrin meshwork, which is filled with platelets and red blood cells to form the matured clot. Okay, so one enzyme that will be able to cleave the fibrin polymers so that they become monomers and dimers or fibrin degradation products is plasmin. Okay, so by activating plasmin, increasing the number of active plasmin molecules, fibrin will be dissolved, and so the clot will be lysed. So um, to do this, we give tissue plasminogen activators, which are the drugs which we use for reperfusion or thrombolysis. Okay, so by giving the TPA, we are catalyzing the conversion of inactive plasminogen into active plasmin. Active plasmin degrading the fibrin meshwork and lysing the clot. After lysis of the clot, blood flow will be re-established distally, no? Distal to the clot. So that's how TPAs work. Examples of tissue plasminogen activators are streptokinase, which is originally derived from Streptococcus, a bacterium, no? Actually bacteria, uh, because there are many species that can produce streptokinase. We have urokinase, which is expressed by urothelium, no? The lining of the genitourinary tract. And we have observed that these molecules, streptokinase and urokinase, are effective in lysing the clot, but they are rejected by the body because number one, streptokinase is foreign, so we develop antibodies with that, and urokinase is not very selective, so it's not as effective as the newer agents. So the newer agents are alteplase, no? Those are already recombinant DNA technology products, alteplase, um, reteplase, and telecteplase. Okay, so those are examples of tissue plasminogen activators. Other important therapeutic adjuncts that we give to patients who suffer from myocardial infarction is number one, pain control. So the pain that is experienced during angina or an ischemic event is very severe, so that patients will often describe that there is a car pressing against their chest, okay? Or there is an elephant stepping down on their chest. So the pain can be very severe. And what is the effect of having severe pain? Severe pain can cause the patient to breathe abnormally, and so ventilation and oxygenation of the blood decreases, and this will aggravate the ischemia in the heart. Pain will also stimulate the sympathetic nervous system. Okay? When the sympathetic nervous system is activated, epinephrine is released, and once it acts on the beta receptors in the heart, it will stimulate contractility and heart rate, which will increase oxygen demand, further aggravating our problem with the balance of oxygen delivery. Okay, so we need to control pain. What are our important options? The most common pain control mechanism and medication for patients with ischemic heart disease are the opioids. So we usually use morphine or fentanyl, okay, for pain control. So next is resuscitation. Remember that the problem um, with ischemic heart disease is reduced oxygen delivery. And what carries oxygen would be red blood cells. And so if patients are anemic, we can, severely anemic, we can give them EPO later, but we can also transfuse them with red blood cells. Um, we want to improve the perfusion of the myocardium, and if the patient is volume depleted, no, we can give intravenous fluid so that the volume rises, and so um, the perfusion pressure increases, and so blood can reach the more distal parts of the coronary. We can load the patient up with oxygen so that even if there is decreased blood flow distal to the point of obstruction, this blood carries so much oxygen that it can supply even a little of what is in debt or what is missing. We can decrease myocardial stress, and this is very important after, no, after and even before the myocardial infarction, no. So um, we can give unloaders of preload, so we want to decrease stroke volume by decreasing plasma volume. So diuretics, or we can cause venodilation to decrease venous return. And those are preload unloaders, or we can give afterload unloaders, decreasing systemic vascular resistance by vasodilation of the arterioles. And so we can use agents such as inhibitors of angiotensin, ACEs and ARBs, or calcium channel blockers, or even direct arteriolar vasodilators such as minoxidil and hydralazine. Okay, so it is also important to advise the patient to not perform strenuous activity up to 3 months after a myocardial infarction, because if we are not fortunate to save the cardiac tissue through reperfusion, our next goal would be to help the patient go through the natural healing process. The myocardium has died, and so the body will have to replace the dead myocardium with scar tissue. And um, in the first 3 months, this scar tissue can be very pliable and it can break off easily. So when that scar tissue ruptures, that is eventual death. Okay, so for the first 3 months, when the scar is quite soft, advise not to do strenuous activity so that there is no rupture. Okay, so that's it for our lesson on acute coronary syndromes. I hope you learned a lot. I want you to um, appreciate why angina develops, and we center that on the balance of oxygen demand and delivery. Uh, Coronary occlusion can be due to a clot and a fibrous atherosclerotic plaque. Um, During an MI, we can perform reperfusion medically or surgically. And adjuncts to treatment are pain control, resuscitation, and a decrease of myocardial stress. So with that, I hope you continue learning. So watch videos or read your textbook, because uh, textbooks are really uh, better than your teacher. Okay. So with that, I hope you Learned a lot, so stay safe.